run our first polling question. And that polling question, I'm wondering if you guys can see that.
It's there.
Okay, thank you, Dr. Sobel. First one is, how is your practice being notified when a patient is discharged from the hospital? Receive a discharge notification from the hospital, event notification from the DIN or CRISP, case manager from Care Link, notification from case manager from hospital facility, or phone call from patient care taker. And for some reason, I'm not able to see this, so I'm going to, okay, I am able to see some of it. Okay, we have a couple more people to go ahead and place their answers. Okay, I'm going to close the poll at this time. Dr. Sobel, we had 54 receive a discharge notification from the hospital. 0 did an event notification from the DIN or CRISP. 0 case manager from Care Link. 23 notification from Care Case Manager from the hospital facility, and 23% phone call from patient and family member caretaker.
Okay, it's interesting. One of the things that we're going to be talking about is the transfer of care from patients from hospital and home, and making sure that there's an efficient method that the patients can get in to see their primary care doc on the outpatient basis. So we'll talk about that. Okay,
great, thank you. At this time, I'm going to go ahead and play the first portion of the pre-recorded part of today's webinar. Once I have that up. Okay.
Thank you for attending this pre-recorded session on Transition Care Management Services workflow. The purpose of this presentation is to help identify patients who are complex and require additional handoff from the hospital setting to the outpatient setting, usually involving a multidisciplinary team of the primary care provider, specialist, community services, and pharmaceutical help. PCM services are documented in the medical charts, and there are CPT-2 codes in order to bill for this. The most important thing is to identify when patients are in the hospital and eligible for TCM services. Various practices receive different types of information of when patients are admitted to the hospital. This can be a Care Link, which is used throughout the Delaware systems. Care Link can message the doctor's office or place a phone call. Hospital lists, calls from patient families, calls from inpatient coordinators, any of these will serve as ways to know that your patient is in the hospital. For those of us in Delaware, we have the DIN system in which you can receive hospital H&Ps, discharge summaries, transitions of care. These two serve as ways to know that your patient is in the hospital. Some practices may be on an ENS service, which is a way that you receive daily updates of patients in the hospital or in the emergency room. The intake process is 2 steps. So there are 2 requirements for the TCM. First, you must have an interactive contact within 2 business days. The important part to remember is the interactive contact must be a licensed clinical staff member under the supervision of a physician. This means that a front desk receptionist does not qualify as a licensed clinical staff member. The second part of the TCM process is the face-to-face appointment. This could be broken down into 2 time frames. The first is a 14-day of discharge, which would be your moderate medical decision patient. The second would be within 7 days, which is your highly medical decision-making process. It is the physician who should determine which day is appropriate, the 7-day or the 14-day. Usually this is made of the number of diagnoses, the amount of care that you think the patient's going to require, and a general understanding of the risk of the patient either ending up back in the emergency room, readmitted, or having some sort of complication. Again, the interactive contact must be within 2 business days. So if the patient is discharged on Friday, Monday does count, and Tuesday does count as the business day. The contact can be via telephone or email, or in the event that the patient is actually stopped by to make the appointment. One important thing to remember is documentation in the EMR should be clear that this is your interactive contact. As far as the physician or the nurse practitioner role, for TCM services to be billed, there has to be clear documentation that several of the following should be completed. Again, this is a list. It is not required to fulfill all of them. It is which ones that are medically necessary. First, the physician should review the discharge information, looking for discharge summaries, continuity of care. Second, which is most important, is reviewing the pending diagnostic tests and treatment. Since we all know this is one area that we don't realize that there are tests that are pending in the hospital that are going to impact the patient later. So having a clear documentation of what tests need to be followed up is important. Other things as interacting with other healthcare professionals, providing education. This could be stuff that you have in your office already, and it's a standard way of passing off to the patient. Services for non-physician staff that can be billed include communicating with agencies and community services, such as home health care, physical therapy, providing a review of medication and understanding if the patient's going to take their medicine. This is often when we find out that a patient was discharged on a medicine that's now not on their formulary. At this point, when medical assistant or nurse can help identify that this may be a problem. At this point, I'm going to pause this pre-recorded presentation and go live for a polling question.
Okay, our next polling question is, how likely are you to implement transitional care management? And we actually have 100% already answering. Oh, a couple changed. I'll give it another minute. I have 32% voted. Can we get some more participation? Okay, I'm going to go ahead and close the poll, and I'll share the results. Dr. Sobel, there is 13% less likely, 33% most likely, 53% already implementing TCM in their practice, and 0% will not be implementing this in their practice.
Well, it looks like at least we're moving in the right direction, having the last category at 0. So that's good.
All right, great. Thank you. Okay, we'll go back to the rest of the pre-recorded session at this time.
I'm sure the discussion from the polling question of how likely you are to implement TCM in your practice can be extensive. One of the pieces of advice that I have is that to break this down into 2 separate workflows. One is how likely are you able to get a phone call to a patient within 2 business days. Start there. If your practice is very busy, if you don't have the staff, try to break this down into small ways of achieving the process. First, see if you can get the phone call out. Second, identify a way to have the patients scheduled within 14 days. If 7 days seems too much, your schedulers can't get them in, the MAs cannot get them in, a doctor's on vacation, try having all patients scheduled at 14 days, and then you can try to bring it into 7 days. This is something that is practice-dependent, physician-dependent, patient-dependent. You need to look at your entire practice and see how you can bring this workflow in. Again, if you feel overwhelmed, bring it in one step at a time. Billing for TCM services. This is where it can get a little complicated. Number one, only one healthcare professional can report a TCM service. What does that mean? That means if a patient is following up with a cardiologist, with an oncologist, with a pulmonologist, they too have the ability to bill for TCM services. The date that you are allowed to bill for the TCM service is 30 days after discharge. If you choose to report the TCM service, if you are the provider in the hospital, you cannot bill for discharging a patient and then seeing them as their face-to-face contact as the same day. You still need to follow the 2-day business contact and then the 7 to 14-day face-to-face encounter. Finally, Medicare does not want us to double dip. So if you are providing care plan oversight, end-stage renal disease services, or chronic care management, this is not, you're not able to bill those codes at the time that you are doing a TCM service. At this point, we have facts and questions here. Gail is going to help us address these questions.
Thank you very much, Dr. Willey. Dr. Marquez was also joining us to answer those questions, and of course, Dr. Willey, you're welcome to chime in. Dr. Marquez, what happens if a specialist bills for TCM?
Well, as mentioned by Dr. Willey, only one provider can bill for TCM. So whoever sends the bill first, basically, is the one who gets paid. So the key is to make sure that your day count is accurate. Day 0 is the discharge date, so you have 30 days to do all the processes described by Dr. Willey and submit the bill on day 30 for TCM. So whoever sends the bill first gets paid. So prompt submission is essential for this to work for you.
Well, thank you very much, Dr. Marquez. Now, what happens if the patient is readmitted or passes away?
Okay, so the idea here for this whole process is to help reduce hospital readmission and reduce mortality. That's the whole purpose of this whole process. So if the patient dies within that 30-day period, you cannot bill for TCM. Now, if you saw the patient during that 30-day period before the patient passed away, you can bill for that under the usual E&M code, but not TCM. Now, if the patient gets readmitted within that 30-day period, you cannot bill for the TCM. You can still bill an E&M code if you saw the patient within those 30 days, but your TCM day count resets to the new discharge date. So, for example, patient came in was discharged on the 1st of the month, got readmitted on the 10th of the month, and discharged on the 12th of the month. Your new day 0 will be the 12th of the month. And so you count from that day moving forward for TCM purposes. But so you can bill for any other visit during that period after the initial discharge using your usual E&M code. So the important thing to remember is the most recent discharge date is your new day 0 for purposes of TCM billing.
Okay, well, thank you very much, Dr. Marquez. Now, the last question is, what happens if the patient calls the office for an appointment? Is that an initial contact?
It can be, but the conversation must occur between the patient or family member and a licensed health provider. So meaning if a patient calls and speaks to one of your clerical staff to make an appointment, that does not count as have a non-face-to-face initial encounter 2 business days after discharge. There has to be a conversation between the patient or family with a licensed provider in your office, either the physician, nurse practitioner, PA, or any licensed nurse, social worker, licensed NA, if that applies to you, in order for it to qualify as a contact within 2 business days, period. So in Delaware, or maybe in some locations or areas, CareLink can be helpful because under CareLink, they have licensed providers on staff who can do that initial phone call for you if you have an arrangement with them. But majority of the time, it would be a registered nurse making the phone call, or a social worker, or even a pharmacist making that phone call for you through CareLink, and making that initial 2-day contact with a patient or family member. So that would qualify, because these are all licensed providers. Again, the point being that if it's a secretary or a non-licensed clinical staff, that would not count for the initial 2-day contact.
Well, great. Thank you very much. That's great information, Dr. Marquez.
At this point, this concludes our pre-recorded session, and I will connect you live with your facilitator.
Okay, today that will, like she said, conclude the pre-recorded portion, and I would like to now turn the presentation over to Dr. Sobel for our live portion. It might take a minute to pull up Dr. Sobel's.
Here we go. Okay, I think, are we there? Do you see my presentation?
We are there.
Okay. All right, we're going to talk about chronic care management. This is another part of the fee-for-service impact that Medicare has made. And the chronic care management really is a relatively new service, begun, as you can see, in January of 2015. And it's designed for the patient who needs more than just the office visit. So if we think about, patients who come into the office, they're seen, they do need close follow-up following that office visit, but they don't have to come back like every week or every 3 days. You may not need to see them again for a month or 2, but you want to make sure that things are going okay, medications are okay, depending on their condition. So that's what the chronic care management is all about. So let's define it. Chronic care management, defined as a non-face-to-face service provided to Medicare beneficiaries. So this is different than all of the other Medicare billing services, because, as you know, most of those, if not all that I can think of, need to be face-to-face. The patient needs to have multiple, at least 2 or more significant chronic conditions, and we're going to take a look at that in a second. And it's expected that these 2 chronic conditions will last at least 12 months or until the death of the patient. And that the patient is at significant risk of death, acute exacerbation, or decompensation, or functional decline. So you need to meet all of these criteria in order to qualify for CCM care. So what are chronic conditions? And here's a list of them. And as it says, this is not limited to just these, but more. You can see on there, cancer, depression, diabetes, heart failure, hypertension even is considered, because uncontrolled hypertension has its own morbidity and mortality. So if you can identify at least 2 conditions in the patient's active problem list that meet these requirements and meets the rest of the requirements that we talked about in the previous slide, there's an opportunity to bill for CCM services. So who can bill for CCM services? Well, it sounds remarkably like the TCM. Physicians, nurse practitioners, physician's assistants, certified nurse midwives, and clinical nurse specialists are all qualified to do that. Now, most frequently, CCM services are going to be billed by the PCP. However, specialty physicians who meet the billing requirements can bill the service. And so you can think of people like cardiologists, pulmonologists, oncologists, those type of people often have very intense interaction with patients outside of the hospital. Now, just like in the TCM, only one practitioner can be paid for CCM services for a given calendar month. So CCM is based on the calendar month. It's not based on 30 days. It's based on the calendar month. So the CMS says that in order to bill for CCM, the patient must have a comprehensive evaluation and management visit or an initial IPPE prior to billing for the service and in order to initiate CCM. Now, the complaint from physicians when this was put out in 2015 was, I've been taking care of this patient for the last 25 years. There's nothing I'm going to learn by providing a comprehensive evaluation, an E&M code or doing an IPPE. I know my patient. So in 2017, the rule was changed that you do not need to bill the E&M visit or the IPPE visit unless the patient is new to your practice, and obviously you would want to learn as much as you can about the patient, or if the patient has not been seen within the last 12 months. And those two conditions, excuse me, you would have to bill an E&M or an IPPE in order to get to a CCM billing. Another note, services have to be provided by an appropriate physician or non-physician or clinical staff, and that could be incident to the billing practitioner, and that's typically with nurse practitioners or PAs. And we're billing for a 20 minutes per calendar month. So you can see on the slide the list of people who are qualified to bill under the CCM. Excuse me, I've got a cold that's kind of dwindling and little post-nasal dripping. Now, the important line is the one at the bottom. Non-clinical staff cannot be counted, so you cannot have your receptionist call and talk to the patient or make arrangements. That doesn't count. It has to be somebody who's able to be billed or can do billing. So that leads to our first question. Caitlin?
Okay, our first polling question now is, describe your position within the practice. Are you a physician and clinician, an office manager, a nurse, receptionist, or other? All right, I'm going to go ahead and close the poll, and I'll share the results. Dr. Sobel, we had 0 physician or clinicians joining us at this time. We had 22% office managers, 0 nurses, 6% receptionists, and 72% other.
Okay, interesting. All right, so at least for the office managers and those people, this slide is a key to making sure that we're successful in this. So how do we start CCM off, as they say? Well, again, first the CCM initiating visit, but remember, if the patient is familiar to you and if the patient is not new or has been seen within the last 12 months, you can skip this under the 2017 rules. So those usual face-to-face requirements, if you are going to bill prior to that, it would be one of these: the annual wellness visit, the IPPB, TCM, or an E&M code. All of those could be billed, and the 44 to 209 obviously depends on which one you're billing. So that would start it off unless the patient is familiar to you. So the basic code for CCM is 99,490. It pays about $43, give or take a little bit. And this was the first one that was established by CMS, and it implies that during the course of the month, about 20 minutes of clinical staff time is directed towards the patient, either by the, well, it's directed by the clinician, but it doesn't have to be the clinician. It could be staff, as we just talked about on the previous slide. And it involves established patients, implementing, revising things, monitoring, whatever you're doing with the patients. So for instance, if you were an oncologist and the patient is just completing chemotherapy or on chemotherapy and is having problems, you need to talk to them periodically to adjust medications or do whatever, this would be the CPT 99,490. And it assumes about 15 minutes of work by the billing practitioner. Now, two things on that. Again, the billing practitioner does not have to be doing the actual work, but it's the assumption that let's assume your clinical staff, one of your nurses is handling all these calls and going back and forth and talking with the patient. It's assumed that the information that's gained by that person would go back to the billing practitioner and be discussed, kind of like a conferencing, no different than that. And so that becomes our basic billing. So this was the one that was originally started in 2015. And Medicare, when they started this, they made the assumption that you probably wouldn't spend more than 20 minutes over the period of a calendar month talking with the patient. If they were that ill, they'd probably come in sooner. And physicians said, no, that's not true. We can manage a lot of patients on an outpatient basis without seeing them, but we can't do it in that 20-minute time. So a additional code was set up called the complex CCM, 99,487, pays about $94, and it says that about 60 minutes, because a lot of physicians said they spend 60 minutes, or their practice does, dealing with these patients on the outpatient basis. Now, again, it's similar to the first one. Again, you're established or substantially revising things going on. There's oversight, there's direction, there's management, but obviously it's 60 minutes per month. It's a moderate high complexity that you're dealing with. And again, just like in the previous code, it assumes that there is input by the billing practitioner into what's going on in discussing the progress of the patient with your staff. And again, this cannot be done by a receptionist. It has to be at least a nurse or higher. And some physicians said it takes us more than an hour. Okay, so in some cases, depending on your clinical specialty, it may take more than an hour to do this, and so CMS added yet another code, 99,489, which adds an additional 30 minutes. So if your office is spending an hour and a half or more, then you would add on this code in addition to the previous code. Again, as you can see, the arrangement is exactly like before, so it's just a continuation, just an expansion of before. With the similar time requirements. If the clinician, the billing clinician personally is performing this, so we're not delegating this to a PA or a nurse practitioner or one of your nurse assistants, but this is done directly by the billing clinician, whoever that may be, unless your PA or NP is directly billing. There's yet another code, this G0506 code. Which again pays $64, and when you look at it, except for the fact that the clinician is directly handling this, similar to what's been previous to this. Now, how do we do billing? Okay, so now I've got the attention of all the billing folks that are out there. The practice must have the patient's written consent in order to bill for CCM services. This was the original rule in 2015, so everybody heard that you had to have written consent. As of 2017, the practice just needs to document that information was furnished to the beneficiaries so that they can be just simply told that this was happening. Part of what was going on was that patients were handed documents, and I'll show you one in a minute, and they were kind of overwhelmed at this. Again, like TCM, only one clinician can furnish and be paid for CCM services during a calendar month. The one who's providing the primary care to the patient is the one who can bill. So it may be a cardiologist, it could be an oncologist, pulmonologist, but usually this is the primary care physician. It just depends on the circumstances. And frankly, practices are going to need to work out who may be billing for the CCM, depending on the case. The patients do face co-payments, co-insurance deductibles under their Medicare policies, and that needs to be explained to the patients. That was the reason for giving the written information when this first started, because patients aren't seeing the clinician face-to-face and are suddenly getting a bill from Medicare or their insurance company going, you got these services, and they said, but we never saw the doctor. We always have to see the doctor to get a bill, and because this was different, so this needs to be explained to them. Now, you cannot bill the CCM code during the same month if you have the TCM codes, home health supervision, hospice supervision, or certain ESRD services. So if any of those occur during that month, you cannot bill for CCM. Just by the way, practices will ask, well, how do I track all this? And most practices, I find, create spreadsheets, a little Excel spreadsheet. And so anybody who touches the patient, if you will, during the month, puts that time down on the Excel spreadsheet, and then at the end of each calendar month, office staff can see if the qualifying 20 minutes are made. If other E&M or procedural codes are provided, these services are billed as normally they would, but they do not count towards the CCM. So if the patient calls in, it leads to an office visit, there's a resulting E&M code, the time would be included in the billing office visit, but not in the CCM. So you can see a patient for an E&M between times, but you can't bill for the CCM if you have one of the above codes. Now, we said that the patients used to have to get written information. Basically, at this point, Medicare now says the only thing you have to do is inform the patient and make sure they understand what the requirements are. So first, they must be told exactly how CCM works, you know, that there's going to be this 20 minutes or longer, depending on what we estimate, and that they have the right to decline or terminate at any time. So if they're unhappy on getting CCM services, they can say they don't want to do that. They need to be told how to terminate or transfer. The authorization of electronic communications and medical information with other clinicians. So part of the expectation is that you will be sharing your information with the other clinicians who may be involved in the patient's care. And so they need to know that that information will be sent to the team. And you know, that's really part of normal good care for the patient. They need to know who the physician is who's going to be providing the CCM, as well as the nurse. And so, you know, Dr. Smith is going to take care of you, and his nurse Mary is going to be the one you're going to hear from. Now, obviously, Dr. Smith and Mary may not be in every day when you call or on a weekend, and we're going to talk about that a little bit. But by and large, they should expect that all the billing will be coming through the designated physician and that nurse. The patient should be told that only one practitioner can furnish and be paid for the service during the calendar month. So here's kind of an opportunity so that if the patient comes to your practice and you say that you're going to practice CCM, and then they go see another physician who says, oh, I'm going to be charging for this CCM stuff, the patient hopefully can say, no, my other doctor is charging for that, so that nobody gets, you know, cheated out of the billing. You should explain the monthly nurse assessment visit, which is basically that you're going to talk to the patient at least once during the month, and it's an over-the-phone versus a face-to-face exhibit or face-to-face visit. You need to explain how and when bills will be generated and what the patient's obligations are. Again, co-insurances and deductibles, and that the visits and the charges will all come at the end of the calendar month, assuming you've accumulated at least the 20 minutes of time. You can review the participation agreement and validate their understanding. And again, it no longer requires a written document. Once all that's done, you record in the patient's electronic chart that CCM was explained and possibly written consent. And you may want to get written consent from the patient and have it documented in the chart, or you can just simply put a note in the chart that the patient accepted or declined services, that they're going to get an electronic care plan, and they have the right to stop CCM at any time. Those are the biggies that Medicare wants to see if they do an audit. So here's why the form was dropped. This is a sample letter to explain to the patient what CCM is all about, and just picture most of your Medicare patients, especially your elderly ones, and you hand them the sheet of paper and they're agreeing and there's a contract, and so this has been dropped in favor of just a simple explanation. Here it is kind of in detail. This is a consent form, and these are available if you like, and a lot of practices like to have this. If it's written, it is. If it's not written, it ain't. So if you really want to have written documentation, it is available, and we'll talk about that in a few seconds. So there's some scope of services and billing requirements that we need to talk about. On the left panel, it talks about the scope of services, and on the right panel it talks about how this interacts with your certified EHR or other electronic technology requirement. So if you go down here to the third block, for instance, access to care management services 24/7, so you need to be available to the patient 24/7 so that the patient can make timely contact with you. And in the practice, they have to have access to the patient's electronic care plan, and this was the bugaboo. So you're on call for your practice, you're at the mall shopping with your spouse, and you get this call from a patient who wants to talk to you. Well, under the original rules, you needed to be able to get to your electronic health record in order to be able to discuss the patient's case with them. And if you're the covering physician, it gets even more difficult. And so this 24/7 rule of having an electronic health record available got dropped as of 2017. Ideally, anybody who's involved should be aware of the patient. Again, at the bottom there, the creation of a patient-centered medical care plan needs to be done, and I think pretty much everybody is familiar with that. The last line required that this be shared electronically with other practitioners and providers, which means sending it electronically from your EHR to other physicians who are involved with the care of the patient. Well, you and I both know that this is not going to happen, right now at the state of how well these things work in life, you can't really share electronically generally with other clinicians. So the rule was changed in 2017 that you could merely have the patient-centered care plan and then fax it to your consultants or the patient's PCP, depending on what was going on. So that's a change that occurred. The scope of services, the electronic copy of the care plan and the document originally had stiff requirements as to how to be in there and how to follow a specific format. That was dropped. Again, the coordination of care with home and community-based clinical service providers, which required an EHR and sending it all electronically, got dropped. And the beneficiary consent and other communications back and forth, again, do not require the certified EHR. However, the clinical summary that you put on, you have for the patient has to be on a certified EHR. So most of these changes really occurred with the fact that we are not yet up to the point where we can freely communicate back and forth. It's not like email or messaging or anything like that you have on your little iPhones and stuff. So all those requirements were dropped, and you can see that they're much more reasonable than they used to be. So I have just overwhelmed you with a lot of things, and this is, it is difficult. There's a lot of stuff happening. There's a lot of moving parts in all this. So if you're looking for additional help, you can certainly talk to us at HealthVisions. Delmarva, you can go directly to CMS and find out the information. So if you go to Google or you go directly to your EHR or to your computer, if you go to www.go.cms.gov/CCM, and so that's what you're looking for, and you go to there, and you just search. You can go on a Google search for CCM, and it'll come up with that CMS website. You get to this website, okay, and this is the definitive and authoritative site. Gives you lots of information, lots of resources. There's webinars, more stuff if you need to go through stuff, review it, and help you with getting this all set up. They even tell you how to bill, so it pretty much really is self-contained. So a lot to think about, an opportunity for your practice. Think about the patients who would benefit from this service, the ones you always have said to yourself, gee, I wish we could do more for the patient, but we really can't devote the time, especially when it's non-compensated. This is really an opportunity. Just on an FYI, you're not going to make 20 minutes with every patient every time, but when I talk to clinicians, they say it's amazing how much I can accomplish and how often we do hit the 20 minutes or even an hour or longer, depending on the patients and their chronic conditions. So that concludes the presentation from my part. Did want to remind you that we have 2 more webinars coming up, May 18th and May 25th, talking about data into information and using it, to help with your practice. I always like to say that the reason for buying an EHR is not to electronically record patient notes. Frankly, it's easier to do paper and pencil. But the data is the key. The data that you collect on the patients as you see them and as you enter it on the EHR really makes a difference on taking better care of your patients, meeting requirements from CMS, from all kinds of people. And so we're going to be talking about that in these 2 webinars on May 18th and May 25th, and I invite you, when you get the invite, to go ahead and sign up, and we'll see you back then. So that concludes my part. We'll open it up, I guess, for questions in the remaining time.
Yes, Dr. Sobel, you had 2 other polling questions. Did you want to run those, or just go into questions?
Yeah, let's run them. I forgot to stop when I was there, so let's run them.
No, absolutely. All right, so the one of them, this is probably my favorite one. What was one thing that drives your practice crazy? You can't get the room temperature comfortable, the phone, running around like a chicken with the head cut off, patients who don't pay their bills, the schedule's overwhelming. So we'll get some people to participate in this poll, and then we'll do one more, and we'll go straight into questions. All right, we'll give it just another minute. Okay, I'm going to close this poll, and I'll share those results. Dr. Sobel, 5% said they can't get the room temperature comfortable, 26% the phone, 21 running around with like a chicken with their head cut off, 26 said patients who don't pay their bills, and 21 said the schedule was overwhelming.
That's interesting. And part of what we're doing here at HealthVisions Delmarva is hopefully helping practices to eliminate all those problems except for collecting their bills. I don't know how we'll solve that one. But certainly, we can change workflow and change how people do things and how your practice functions. I mean, practices are kind of, they just develop over time like Topsy, and they're the way they are because we always did it that way. And so often there's real opportunity to change workflow and how things are different and how you can make them different and utilize your staff more effectively. So I would invite you to stay tuned to HealthVisions Delmarva, so that we can actually transform your practice.
Okay, and then the last polling question that we had was the schedule that you guys are currently using: chaotic, traditional, open access, carve out, advanced access. We can get some participation. for this last polling question, and then we'll go straight into questions. Give it another 30 seconds. Okay, I think we're going to stop right there. I'll share those. We had 10% chaotic, 70% traditional, 10% open access, 5% carve out, and 5% advanced access.
Interesting. Okay. All right. Very good. Let's open it up for questions then.
Absolutely. So I have two questions already in the question queue. One of them said, so am I understanding correctly that the TCM code cannot be billed until the 30-day mark after discharge, date of discharge?
That is correct. Obviously, Medicare is waiting to see whether the patient gets readmitted within the 30 days or dies. And so you have to hold the billing. Practices hate that. I know that. So you put in a charge and it's kind of like hanging out there, but that's the rule they've established. Okay.
And then the second one was, isn't a care plan required to be documented for each CCM patient? What are its elements?
There are a number of things that go into there, and I would suggest that you can look that up on the Medicare website. But yes, there are standard things that need to go in there. And I don't have the list offhand in front of me.
Okay.
Same as for CCM. Same as for CCM, you need to have a care plan set up.
Okay. Another one is chronic pain management specialist is eligible for this service?
Yes. If they're a billing physician, they can certainly do that. Obviously, that would be a patient, who is checking in frequently, or you're checking in with them frequently, managing their medications, that would qualify. But again, they would need to have 2 chronic conditions that meet the requirement. So you have to make sure you get all the elements going forward. They'd have to have 2 chronic conditions that are expected to last, for the year.
Okay, thank you. At this time, that's all the questions we do have. I'll go ahead and leave the line open for a couple more minutes in case anyone else wants to ask any more questions. I also want to remind everyone that today's presentation was recorded and we will upload it to the HealthVisions DelmarvaPTN YouTube channel. Also, you can download today's slide decks, both of them the pre-recorded session and Dr. Sobel's portion. I have them in the handouts in your taskbar. Dr. Sobel, I have Cindy Eisman here. She'd like to ask you a question.
Hi, Dr. Sobel.
Hi, Cindy.
I think that it sounds like something that was going through my head as I was listening to this was, we're working on a lot of different transformation activities with practices. Maybe we're helping them to do better with the MIPS quality measures that they picked. We see a lot of practices looking at like A1C control or hypertension. You could use this process and focus it on a population, right? So if we're working on trying to improve those A1C scores and we identify that some care management services might be helpful for that, practice could kind of pilot using this with just that population. Would that not be correct?
Yeah, as long as they have 2 chronic conditions, they absolutely could. And most diabetics have at least 2 chronic conditions.
Okay.
So, yeah.
That's good to know, because I know that, just the cost of having the staff to be able to do that is sometimes a concern for practices. And, well, this isn't a boatload of money. It gives you a little bit of dollars to offset the cost of being able to provide that service. So I just wanted us to all keep that in mind. So thank you.
Yeah. I mean, you have to think about the fact that as clinicians, we touch the patient, 15 minutes, a half an hour, maybe 3 times, 4 times a year. And the rest of the time, they're out there in the world. So the odds of being successful are not great necessarily. but the opportunity here to be able to contact the patient, update, find out how the patient's doing. For instance, patients who are diabetic, how are their sugars doing? Are they testing? You know, all the things that we wish we knew about, we can actually follow up with under CCM.
Okay, thank you.
Okay,
Sure.
Doctor, we had another question come in. Is a patient with chronic neck pain, chronic back pain considered two chronic problems?
I don't think they would qualify. I'm not sure. You'd have to check a little deeper on the Medicare side, but typically they're looking for other things other than pain. I've not seen pain listed as a chronic condition. You know, the pain is not a condition. I mean, you could argue it, I suppose, but the pain is not a chronic condition that's going to lead to the demise of the patient or serious deterioration. It's just chronically there. So it probably would not qualify in and of itself. Now, if on the other hand, the pain is interfering such that the patient, you know, it interferes with, let's say, their congestive heart failure. They can't exercise or they can't do whatever they have to do, then that may, you know, help you in getting there.
Okay. Well, Dr. Sobel, I appreciate your time today. Actually, I'm sorry. I have Barbara who has her hand raised. I'm going to go ahead and unmute Barbara's line. Barbara, your line's unmuted.
Hi, Dr. Sobel.
Hi.
I have one question. I think it said that certified medical assistants could work under the physician.
Correct.
Okay. If a medical assistant's not certified, though, they cannot do that?
That's my understanding.
Okay. All right. Because I saw also you had technical assistance, and I guess the requirement has to be certification.
Yeah, some type of licensing is what's required. That's why the receptionist is not allowed to do it.
Okay. Okay. Yeah, because a lot of practices that I work with have medical assistants, but they're not certified. So. Okay.
Yeah, there's a skill set that I guess Medicare wants to have, and make sure that whoever's dealing with the patients has that certain level of clinical qualification.
Okay. Well, thank you very much. Appreciate it.
Thank you, Barbara. All right, Dr. Sobel, I think we've kind of slowed down with the questions. Again, everyone, we will be sending a follow-up email, which will include the slide decks, if you have not already downloaded them from the handouts. A copy of today's recorded webinar will be uploaded to HealthVisions on our YouTube channel, and I'll send everyone that link. As well as all the questions that were asked today, we will send a document basically with the question and then the answer that was either given, maybe with some more information if we're able to pull or obtain that. Again, Dr. Sobel, I appreciate your time, and that's going to conclude today's webinar.